Hello, I'm Jan Lathan.
Hi, I'm Gayatri from Ilmenon.
Welcome to MedNews Week Conference, where we feature presentations by medicine's global leaders. Today we have an amazing keynote speaker in Dr. Brian Kim. Dr. Kim currently serves as the inaugural director of the Mark Lebwohl Center for Neuroinflammation and Sensation at the Icahn School of Medicine at Mount Sinai. He also serves as the Sol and Clara Kest Professor, the Vice Chair for Research, and as Site Chair at Morningside West campus of Mount Sinai.
In today's presentation, Dr. Kim discusses the etiologies and potential treatments for the different types of inflammation.
Did you know that Dr. Kim is an internationally recognized researcher who has led multiple clinical trials, including for Ruxolitinib, that received FDA approval for the treatment of atopic dermatitis, and Dupilumab for the treatment of Prurigo Nodularis? He was also the first to discover the role of group 2 innate lymphoid cells in the skin of mice and humans, and the role of IL-4 and IL-13 and the JAK kinases in sensory neurons that mediate itch. He also described the roles of basophils and NK cells in atopic dermatitis pathogenesis, and received a patent for the use of JAK inhibitors for chronic pruritus.
He's truly a pioneer in the field of dermatology.
So let's tune in. Let's tune in and learn from this global leader.
So how do we sense the world around us? And we typically think of this as the five senses. As I've already mentioned, many of these sensations can be very, very important for survival. And Nobel Prizes were awarded for the discovery of specific science underlying these different kinds of sensations. Most recently, the Nobel Prize in 2021 was actually given to Artem Patapoutian and David Julius for the discovery of touch as well as temperature sensation in the skin. And so we know that these sensations are important when we think of the five senses, but what if we actually break this down much further? And maybe there are sensations that actually don't fall within these categories necessarily. We could put, for instance, pain and itch under touch. And so we know that these sensations are important. So if we think about pain, if one imagines, what if you actually didn't feel pain at all? Would that be an advantage? You might think that this is a superpower of sorts, but actually it's a big problem. Actually, patients like Ashley Blocker, who are actually born with mutations that actually make them resistant to pain, can be very, very dangerous, have a tremendous amount of morbidity, and can be deadly. And you can see here, she's actually bandaged by her mother because she actually would bite her fingers and would hurt herself without even knowing it. And in fact, patients like these can actually suffer tremendously and actually lose limbs, and it can be very, very tremendous morbidity and even be deadly. So we know that sensations are important for survival, but is itch important? And it's something that I don't think immediately is obvious. But before I really talk about itch and whether it's important or not and how this plays into our lives, the first question to ask is, what is itch? So the medical term is pruritus, and we refer to this as itch, but it was actually defined by a German physician named Samuel Hafenreffer in the 1860s, I believe. And it was defined as actually an uncomfortable sensation on the skin that causes a desire to scratch. And in contrast to the sister sensation of pain, which is defined as physical suffering or discomfort caused by illness or injury, one can imagine, though the definition is quite appropriate, does not immediately elicit a sense that this is something that's important, that this is a medical issue that needs to be solved, quite in contrast to pain. And I'll come back to this a little bit later as well, but I think our definitions are very important because they actually assign a lens with which we actually view this subject. And perhaps this is the first step in why itch may have been overlooked so tremendously over time. And I'll come back to this a little bit later as well. So the question is, why do we itch? And the reality is, in contrast to some of the other sensations I've listed already, the evolutionary reasons for why we itch are not immediately or obviously known. They remain somewhat unproven. And perhaps this is another reason for why we have actually underestimated the importance of itch as well. But we can speculate. So one can imagine, for instance, that itch may actually be important, for instance, to sense different kinds of parasites and insects around us. And it's obvious why you'd want to sense a parasite, but itch also evokes a certain kind of mechanical reflex to remove larger parasites from your skin in a way that may be actually conducive and actually cooperate with the immune response that's required to expel a parasite. So for instance, you don't really want to itch in response to a bacterium or a virus necessarily. That won't be very productive, but for a larger burrowing parasite, this could be very productive because scratching is a reflex that could perhaps help expel. But also one can imagine things like mosquitoes that are elicit very itchy kind of bites are a great way for us as a species to actually sense that there's something perhaps disease-borne in the environment that's not good, but that's not immediately aversive like a bee sting, where we actually still need to be in that environment to get whatever we need to get done, but still sense that perhaps it's not the most favorable place to stay. But also in modern day, we know that many, many pathways, lots of pathologies in the body actually lead to the sensation of itch. So we actually are starting to think that perhaps itch is a way to tell the host that maybe something is actually wrong inside, that you might have a lymphoma, you might have kidney disease, your liver might be failing. And it's a good way to also, in a more subtle way, tell the host that maybe it's not a good idea to be going out, say, in early days on a major hunting expedition if you're very itchy and you'd rather perhaps stay home. But notwithstanding all of the unknowns about itch, one thing we do know is itch is highly conserved across many vertebrate species. So it's actually thought that even fish can scratch, and they'll itch and scratch, and they'll rub themselves against a rock. And it's rather surprising how many different vertebrate species actually do itch and attempt to scratch. And this is just to bring it to life a little bit. Here are some examples of many different animals that will actually attempt to scratch. And we know, for instance, dogs get very itchy, and there are actually a couple FDA-approved drugs that actually alleviate itch in dogs. And actually, the advances in veterinary medicine were actually much further along and have been much more innovative in some sense than what's happened with regard to human medicine. But the question is, why should we care? If we can debate whether itch is important or not, but why should we really care? At the end of the day, the problem is when itch becomes chronic. So when itch lasts for greater than 6 weeks, if it lasts on the order of 6 months, 6 years, 10 years, 15 years, which does happen, and these are patients that I see, and this kind of chronic itch state affects greater than 15% of the population. The negative impact on quality of life is tremendous. It's equivalent to chronic pain, perhaps in some cases worse. Its incidence is increasing because the incidence of itch is actually very much tied to aging. And there are really no FDA-approved medications that are really specifically targeting itch as a primary disease entity unto itself. There are now FDA-approved medications in which we actually treat itch associated with the disease. But for instance, we can't just say we're going to use this drug on label just for chronic itch, not otherwise specified. But we also know that itch can really affect people's lives. And on the left is actually a famous painting of a French revolutionary, Jean-Paul Marat, who was actually assassinated in the bathtub because he had a very, very chronic itch condition which we to this day do not know what it is. I suspect that it's a condition called dermatitis herpetiformis, or what we refer to as During's disease. And it was known that he was always in the bathtub, and it's why he was actually susceptible to being assassinated. And on the right is the depiction of the one of the circles of hell in Dante's Inferno, in which counterfeiters were actually relegated to. And so it was understood already in literature that itching was so hellish of an experience that if it were, it could be actually a punishment to subject individuals to eternal itch. And here's an article from the New York Times just from the last month, in which an individual experienced a rash that wouldn't go away, and it was really the itch that was ruining her life, and she was really tormented by this. And I think it really speaks to the fact that you hear these stories over and over again, and it was only when she was actually diagnosed with red meat allergy that finally her providers could figure out how to treat her and make her life better. But regardless of the cause, the itch was what was driving her crazy. The other thing is that itch may be the most common medical symptom. If we actually think about symptoms, there are so many diseases. It's definitely the most common symptom in dermatology, but there are many, many disease states, whether infectious or cancer associated or even medication associated, neurologic, systemic organ dysfunction, or even what we call idiopathic or unknown causes of itch that actually affect patients. So we really think this is a very, very common symptom. And here are just a list of dermatologic diseases that really run the gamut, and depictions of everything from atopic dermatitis, or what we refer to as eczema. And I'll come back later to notalgia paresthetica, which is a neuropathic itch condition. So it's your nerves actually going awry. I already mentioned During's disease, which we think Jean-Paul Marat had. I'll also mention perhaps a little bit later is there are drugs now approved for uremic pruritus. So these are patients who actually are on dialysis and develop very severe itch. And there are a number of other conditions. There's Prurigo Nodularis shown here, which is also a primary itch condition. But the list goes on and on. I could spend the whole hour talking about all the different itch conditions. But I actually mentioned why itch may have been ignored. So I talked about some of the out of the gate issues, perhaps in terms of the definition, our perception of it. Is it important, evolutionary importance and all? But there are some other things I want to cover, which is that itch was actually thought to be a mild form of pain, and this was a misconception. So this led us to think that pain remains the most important issue, and if we simply study pain better, we could actually solve itch. And this was a myth that had set back itch research in some ways. Itch is also associated with many, many diseases that we're not really proud of. Communicable diseases like scabies, bed bugs, lice, body louse, things that are traditionally were actually difficult to treat in the old days. And it's actually entered into our kind of social consciousness that these are very shameful symptoms to have, oddly enough. And it's actually something that, as a provider who sees patients, I sense all the time. They're actually very afraid to actually even bring it up in many ways because they feel they're not going to actually evoke a lot of empathy. There's also this misperception that people who itch are simply having a psychiatric disorder. and the kind of quote unquote, it's in your head, quote unquote, you're crazy. So it's very, very, and patients know this, so they're very fearful of being stigmatized in many ways. And then the fact that there were no effective treatments, it's only within the last few years that we're starting to see major advances, and I'll speak to that a bit. And then lastly, itch is subjective. So particularly Western medicine is very, very fond of objective readouts. So if you do a biopsy, if you do an X-ray, you do a laboratory test, these are all great things in Western medicine. And these make us believe this is a real disease. This is something that's serious. This is something we're going to go after. But if you say things like, I hear ringing in my ear, or the room is spinning, or I just feel discomfort, I feel itchy. These are not generally things, in my opinion, in what Western medicine knows how to handle. For one, we don't have good solutions for them, but also the subjectivity inherently within the Western paradigm in many ways is associated with a lower level of importance in the hierarchy, despite the fact that subjective disorders can be incredibly debilitating for our patients. So what can happen when itch is ignored? This is an example of, at the time, a woman who was 51 years old who's presented in my clinic, 1 year history of severe generalized itching, extreme anxiety and depression. She was actually treated with numerous psychiatric medications. She even had a surgery during that period. She had been seen by many, many providers. By many, I mean at least 6 dermatologists, multiple allergists, primary care physicians, and essentially could not make any progress. She came to my clinic, and we have a very standard workup. As you can see, given the many associations for itch, we have a very standard workup we do. We don't really think too hard. We simply go down the list to make sure these individuals don't have something we're missing. And in fact, what this woman had was actually a large lymphoma in her chest, or what we refer to as the mediastinum. And the radiologist called me, and this was actually a lymphoma. And within 1 week of being treated for the lymphoma, her itch completely went away. And so, and I'm still in touch with this patient to this day. And it was what was shocking to me was when I actually called her, she actually said, "This is the best news I've ever heard." She was actually delighted to hear that she had lymphoma, because for once she had an answer for why she was so itchy and so miserable, and really you're verging on suicide in many ways. So it really speaks to how perhaps that's a great example of how we don't take itch as seriously as we perhaps could, even when it could be a harbinger of something serious. And but also the fact that something serious like a lymphoma was not the primary concern of my patient, but actually her itching. So how does the skin actually sense itch? Well, we have to, if we think about the peripheral nervous system, there are actually 2 things that the peripheral nervous system does. And we break this down into the autonomic nervous system and what we refer to as the somatosensory nervous system. And traditionally, it's broken down in terms of direction. The autonomic nervous system directionally goes outward, and it sends signals to your body, and it regulates things like heart rate, breathing rate, your intestinal motility, and in the skin, it'll regulate things such as sweating and the blood vessels to your skin. The somatosensory nervous system, or the sensory nervous system, moves in the other direction. It takes signals from the body, and it takes it back to your brain through the spinal cord, and so the direction is very different. And then the somatosensory nervous system is very sophisticated. There are different kinds of nerve fibers that have very different kind of anatomic structures and go to different parts of the skin and different have different functions to sense, for instance, your hair shaft moving. It can sense even some elements of friction on the skin, mechanical sensation. If I were to poke one's skin with the end of a Q-tip, or more subtle things such as itching, mild forms of pain or severe forms of a skin prick pain, temperature, heat, and cold. And it's really the latter sensations I talked about that are mediated by these red nerve fibers called polymodal C fibers. And it's really a small subset of these that actually mediate itch. And I mentioned the Nobel Prizes earlier, and it's really the right side of this picture actually was in many ways in my mind put on the map with the Nobel Prizes for the discovery of how we sense temperature and touch. But we're speaking really about itch. And how does itch really work? So if we take a molecule like histamine, if we inject into the skin, we'll elicit itch. The way it does is if you inject histamine into the skin, it will stimulate its peripheral sensory neuron. This will send an electrical signal to the spinal cord. You'll dump what's referred to as a neuropeptide into the spinal cord. It'll fire off further electrical signals that will then activate neurons that go to the brain, and then you'll perceive itch. But the question is, how does this actually evoke a scratching reflex? And we do think this is truly a reflex. So what happens is that within the spinal cord, what we refer to as an efferent neuron that projects outward back to the body into the tissue gets activated as well. As much as we sense it, we also trigger this nerve, and then this releases neurotransmitters that then act on the muscle, and this tells us, okay, we're scratching. And so it's really this kind of reflex arc. And I want to underscore that, of course, I can scratch myself and think about scratching, but also you scratch in your sleep, and it's actually truly a reflex. So and that's something that's actually very profound, because itch represents a spectrum of the unconscious to the conscious. And so you can very consciously sense itch, but you can also unconsciously sense itch and in a very reflexive manner scratch. And I'll come back to that later and why that might actually be important. But I mentioned that there were some scientific misconceptions, and the idea really came by way of the fact that it was observed by von Frey in the early 1900s that a stimuli that evoke pain in the skin, if you actually stimulate with a lower intensity, what actually happens is that you actually evoke itch. And this is true of certain kinds of stimulants. But this actually resulted in the crystallization of what's called the intensity theory of itch, that itch is simply a mild form of pain. But this we don't think is actually true. And in fact, beyond thinking about histamine, other non-histamine molecules, or what we refer to as pruritogens, which are itch-inducing stimuli, have been discovered that activate other receptors. And I won't get into great detail, but there are receptors called MRGPRs and these peripheral neurons. And then there are neuropeptides called brain natriuretic peptide that dumps into the spinal cord. And then there are these specific GRPR positive neurons within the spinal cord that are very itch specific. And then there are foci within the brain that receive these signals. And it was really with the advent of this fundamental molecular identification of the science. And what these studies actually showed is that this pathway is very, very itch specific. So these pathways have actually nothing to do with pain. So it's entirely a parallel circuit in many ways. And this led us to believe that we really need to focus our attention on itch itself and not just think of it as a younger brother or sister to pain. And I actually did not start off as much of a neuroscientist. I was actually a card-carrying immunologist, and the question for me initially was understanding what really causes rashes in the skin. So what are the inflammatory mechanisms? But of course, in more recent years, we've become interested in understanding how this inflammation actually triggers itch. And really, this is the nexus at which our science really actually resides. And we used atopic dermatitis or eczema as our kind of model disease. It's a common disease. It's a chronic and relapsing disease of high incidence. Therapeutic options were tremendously limited when we first embarked on these studies, but itch was always the central symptom. You might know patients with this. You might have it. You might have a sibling, an aunt, and you might also find that these individuals actually might have asthma or food allergy or other kind of what we refer to as atopic or allergic conditions. And the classical kind of concept when we first embarked on these studies was that you have an immune cell here on the left. We'll refer to that as a lymphocyte, and it responds to different immune activating factors, which we refer to as cytokines, essentially hormones that are specific somewhat to immune cells. And you can activate receptors on these cells, and these cells get very activated. They rely exquisitely on a downstream molecule called Janus kinase, or JAK, and I'll come back to that. That in turn activates another molecule called STAT that goes into the nucleus of the cell and then changes the program and makes this cell very angry and activated. But in turn, in addition to responding to cytokines, they in turn produce cytokines. And these cytokines then act on the tissues and can cause inflammation, or in my case, in my field, the rash. But in 2017, our laboratory actually had identified that these immune hormones or cytokines, which were thought to really only communicate within the immune system mostly, actually directly communicate with the sensory nervous system. in other words, these cytokines, for instance, like what we refer to them as interleukins or ILs, IL-4, IL-13, IL-31, these cytokines actually directly communicate with sensory nervous system. What we found is that very canonical or just classical cytokines that were really thought to be confined to the immune system actually are used to communicate with the sensory nervous system and act as, in a way, as neurotransmitters. And this was an important discovery for us because this started to explain to us why a rash actually causes itch. And so there are drugs, and I'm going to speak to this a little bit here, is that there are drugs that can actually block these cytokine receptors. There are drugs called JAK inhibitors or JAK inhibs that actually inhibit this JAK, and it can shut down inflammation. And we've known about this for a while now. This is not a mystery. But what our work was able to unveil is that perhaps some of these drugs, at least, that overlap, where these cytokines act on the sensory nervous system, can actually act in a way where they actually modulate the nervous system. So sure, they are anti-inflammatory drugs, but maybe the potency for shutting down itch works in a way that they can actually anesthetize the nervous system and really have, perhaps in some cases, very little to do with the inflammatory effects. And these are cytokine blockers or JAK inhibitors, which I'll be speaking to a little bit. And this actually led us to actually hypothesize that, in fact, JAK inhibitors would be very, very appropriate. And here is a JAK inhibitor called Ruxolitinib. It inhibits actually two forms of JAKs downstream of that receptor. But what we found was really important was this JAK1 molecule. And we actually shared this data before any JAK inhibitor was actually approved or really far along in development. With a company called Insight, and we actually designed a clinical trial. And we really considered and put itch front and center in the clinical trial design because of the science we were doing. And in fact, this drug has very good effect on itch. And the drug is now approved as of this fall. And you can actually prescribe this drug. You can get this drug off the shelf. But we have, in addition to atopic dermatitis, our paradigm is actually very, very broad now because we see all patients who walk to the door with any kind of itch. And I mentioned there's so many different kinds of itch. So in our clinic, we've had patients come from all over the country, fly into our clinic. And this is very important because these patients often don't have atopic dermatitis or a condition that's well recognized. They have conditions that are harder to diagnose or entirely what we refer to as unknown cause or idiopathic. But they may have conditions such as Prurigo Nodularis, which actually was not well recognized in medicine until recent years. And these are actually, this is a condition in which patients actually itch first. So they don't develop a rash first, they actually itch. And then they start scratching their skin and they'll give themselves these bumps or what we refer to as these nodules that are very, very firm. And Prurigo Nodularis was actually very overlooked, but what we actually hypothesized was that based on the discoveries we had made, that some of these drugs that were now working to alleviate itch in atopic dermatitis could even be used here because they would actually have broad itch anesthetic effects by acting on the nerve. And in fact, we pitched this very strongly to Regeneron, and Regeneron, in fact, did go directly to phase 3 with this. And had very good results in the fall of 2021. And we think this yet will be another drug for itch that will be FDA approved by the end of this year. So very exciting. We're moving on to other itch conditions beyond the ones that are well recognized. But we also have patients with chronic itch of unknown cause or chronic itch of what we refer to as chronic pruritus of unknown origin, CPUO. And we've also used these agents actually off-label in these patients because they are incredibly these patients are suffering. They've failed so many therapies. They're incredibly refractory. And you can see, as in this individual, he actually does not have a rash. So he does not have eczema. He just has scratch marks. And he doesn't have scratch marks where he does not reach. So in dermatologic terms, this is referred to as secondary lesions. This is not a primary rash. This is everything that he gave to himself, secondary to his itching. And you can see that he clears up very nicely. This is very anecdotal. This is just really our experience from our clinic, but we published this, and then we were also able to, we think, inspire then these companies to now go further into even chronic pruritus of unknown origin. And this trial has been actually enrolling since March of this year. So we're very hopeful that we'll see yet another win in the near future where these drugs can actually heavily impact patients with conditions that are largely ignored. But on downstream of the cytokine receptor, the dupilumab drug I mentioned blocks the cytokine receptor. It blocks IL-4 and IL-13 at the receptor level. But downstream of that is the Janus kinase of the JAK. And we can inhibit that. And we actually, there was already a JAK inhibitor approved for rheumatoid arthritis called tofacitinib. It blocks JAK1, inhibits JAK1, but also other JAKs. And in these severe refractory patients with CPOO, we were actually able to see good effect, very anecdotally. And we feel that this would also warrant randomized clinical trials to evaluate efficacy to see if patients would also have this at their disposal in the clinic in the future. We actually were able to actually get a patent on this at the time. This is when I was at Washington University before I moved to Mount Sinai. And so it was really, this was in my mind a way to really validate to ourselves that we were doing novel things that were having actually novel impact in terms of even how drugs could actually be developed. But notwithstanding this, the clinical pipeline for drugs that inhibit these cytokine pathways or these Janus kinases or JAKs is one of the most active areas entirely in the field of dermatology and really spreading across the whole field of medicine. I've talked a lot in the first part here about how these pathways actually in chronic inflammation, in the lesions, chronic itch. But in the last year or so, we've also discovered that allergens can also activate other cells, these very rare, almost vestigial cells called basophils, and elicit a totally different form of itch. In fact, an acute itch flare. So when patients actually experience a very severe flare suddenly over the course of a day or two of their itch, we've identified other mechanisms as well, which we think are very targetable in terms of therapeutics in the future as well. We've also looked at patients who have dry skin. So these CPO patients, they don't have much of a rash, as I mentioned, but they do have dry skin. You see this kind of white, dry, flaky skin here. And we've actually identified by modeling in mice that, in fact, even in the absence of robust inflammation, you can, when you have this kind of dry, flaky skin, these mice can be very, very itchy, but the immune cell infiltrate can be no different between the mice that are treated with simply vehicle control or mice that are actually treated with this irritant. It's a mixture of acetone and ether and a challenge with water. It really dries out the skin and causes this kind of dry skin. But it's really a dry skin itching that we think that we evoke in these mice. And my graduate student, Anna Trier, what she actually identified was this cytokine called IL-33 gets very elevated in the barrier, in the outermost barrier of the skin, in both atopic dermatitis as well as patients with chronic pruritus of unknown origin who have dry skin. But when we modeled this in mice, the sensory neuron's ability to respond to this cytokine is critically important in the setting of dry skin, but not so much in robust inflammatory atopic dermatitis-like skin. So this, we think, actually can direct clinical development to say that perhaps drugs or antibodies that block this pathway would be much more appropriate, say in patients with dry skin or chronic pruritus of unknown origin, rather than in atopic dermatitis. And this is how we kind of help to kind of usher the therapeutic landscape and give preclinical hints of which directions perhaps best to go with these therapeutics as they're developed. But we also think that itch is a paradigm of many, many diseases, that itch may actually represent things like even itching of the eyes, sneezing, coughing, bowel dysmotility, even migraine headaches. And I'll come back to that in a bit. Well, so as an example, we actually know that the nervous system can respond to opiates. So for instance, morphine and say fentanyl and these what we call mu opiates, they mimic mu endogenous opioids. They actually activate sensory neurons in a certain subset of patients and cause a tremendous amount of itching. But it's really, the question then is there a way that we can actually suppress the nervous system from itching? If these things activate, is there another way? And there's actually a cousin to the mu opioids called kappa opioids. So there are endogenous opioids called kappa opioids or dynorphin, which both in the peripheral nervous system, spinal cord, and even the brain is thought can actually suppress itch. And what we think, this is a bit controversial, but what we think is that kappa opioids can be particularly useful in the peripheral nervous system to activate other nerve fibers they're more touch nerve fibers rather than itch nerve fibers to actually then suppress itch within the spinal cord. So this is what we call gating out. If you actually activate this pathway within the spinal cord, it can actually choke off other signals from hitting the spinal cord. And there are drugs that can actually do this. So with our itch stimuli, as I mentioned, cytokines that might work through JAK1 and activate itch. But what we know is that there are drugs like difelikefalin or nalbuphine, which actually can stimulate the kappa opioid receptor, or what we refer to as KOR. And then this can actually suppress itch through the mechanism. So this is a pharmacologic or drug-based way that we can do this. These are touch fibers, we think. So we think that this is a kind of a drug-based way of actually eliciting a scratching sensation in a way to suppress itch. At the end of the day, the reason why we scratch is we're trying to suppress the itch sensation. We're trying to scratch to activate and gate out this kind of itch sensation. And we can titrate this perhaps and limit the itch. And in fact, I mentioned a condition that's a neuropathic condition where it's actually, you itch in the middle of the back earlier. Many people have this. In fact, people who are listening to this talk might say, I actually have that, where kind of in the middle of the back, I itch. And it's why we think the back scratcher was invented. But of course, some people will have mild forms of this, and others will have very severe forms where they can't sleep, they can't work, they can't concentrate. Well, in fact, difelikefalin, a kappa opioid receptor agonist, which we actually did a lot to actually push the early kind of concept and really push Cara Therapeutics to move forward in that, just reported last week, very positive phase 2 clinical trials in this condition. So this is quite unbelievable to me, because this is an itch condition with not really essentially no drug that really works. And now we have, for the first time, phase 2 clinical trials in a large study showing efficacy. So in light of many of the successes that I've highlighted, I actually wrote an article for the journal Neuron recently highlighting the translational revolution of itch. In other words, that itch biology, despite the fact that it has been overlooked, underfunded in many ways, a very small field, in many ways trivialized. However, the recent advances have really led to a huge return on investment, so to speak. The hits have been really high. The batting average has been incredible. I'm highlighting the tables here, the table on the right, all the different pathways that are very itch specific and itch selective effects. And I mentioned difelikefalin, and I actually published this a little bit before I even knew the results of the clinical trial that I mentioned with difelikefalin. So I actually think that it's even more true that this is a true revolution than even when I wrote the article just a few months ago. But there's something else that's quite interesting that's going on, is that there's the vagus nerve that's within the body cavity that actually regulates physiology within organ systems such as the gut, and the heart, and the lung. But also 80% of this vagus nerve is actually sensory. And actually, the question then is, what exactly does it do? What is it sensing? What are you sensing from your heart? What are you sensing from your lung and your gut? Well, what's interesting is if you actually do RNA sequencing, so if you actually fingerprint the entire vagus nerve, the top hits you get are itch nerves. These MP1, MP2, MP3 nerves are actually itch nerves. They were defined within the itch nervous system and the somatosensory nervous system, and they actually exist. So the question is, if you don't itch in the gut, the heart, or the lung, what are these nerves doing? And I think it's a very provocative concept. So what do the sensory nerves within your body really do? We have these dorsal root ganglion nerves that go to the skin, but these nerves also go to the body cavity, the lung, heart, gut. And then you have the vagus nerve that is also very sensory. And the question at the end of the day is, if you don't itch, why do you have itch nerves within the body cavity? Well, what we think is that itch, in many ways, at the molecular and cellular level, actually represents a whole host of other sensations within the body, and even, say, coughing. And this goes back to this KOR agonist. So Trevi Therapeutics also has a KOR agonist. It's also an antagonist to the mu opioid receptor. But notwithstanding that, it's not a coincidence that it's a KOR agonist, just like difelikefalin for notalgia paresthetica, which also reported positive results for chronic cough in the setting of patients with idiopathic pulmonary fibrosis. So what's interesting is you have now a similar kind of drug working for both cough and itch. And what we think is that itch does represent things like cough, perhaps bowel discomfort, and other kinds of bad sensations that even come from the body cavity. And I'll take it a step further. This is a recent study that looked within nerves, the trigeminal nerve, which is actually in your head, and actually is the sensory nerves from above your neck, mediate sensation. But if you go from, and what's interesting, and there is that there are nerves that are like itch nerves that I've circled here as well. These are essentially itch nerves. But this study was in the context of migraine headache. I suffer from migraines as well, and I think of it as pain. But the question is, how much of it is pain and how much of it is like itch? And this is a big question. And not only that, these nerves actually are loaded with what we call neuropeptides. So not only do they sense, remember I talked about the direction from the outside back to the brain, but these nerves actually have the capacity to also go in the other direction and regulate inflammation in the tissue. So they're bidirectional. So they take things back to the brain and say, hey, you have a migraine headache, but they also release things into the environment to perhaps be pro-inflammatory. And so the question then at the end of the day, is irritation like itch more than just a sensation? Is it actually a truly pro-inflammatory state? And it's kind of a provocative concept that remains unproven. So we're asking the question, is itch really the tip of the sensory iceberg? Does it actually better represent other things such as headache, cough, reflux, nausea, irritable bowel syndrome, interstitial cystitis, which is an irritation of the bladder? Have we in some ways overcalled things as pain that are uncomfortable? And is the biology of itch actually much bigger than we ever really thought? I suspect that is the case. So for the last part, I'm going to ask the question here, how can we objectively measure itch? I mentioned earlier on, one of the biggest problems is that itch is subjective. So someone could simply say, well, I don't really believe you, and then you're done. But the question is, can we actually objectively measure itch? And it comes to the fact that it's a reflex. So yes, we can. And we have a very close collaboration with Dina Katabi, who's a MacArthur Fellow. She's a pioneer in terms of the development of artificial intelligence machine learning devices. And I'm going to speak to that a little bit. So she has a device called Emerald here that you put in your house. And it uses radio frequency and it bounces signals off from the environment. And it can actually sense an individual moving within the house, someone who is, say, moving, and then suddenly they fall down, and you could detect that the person has fallen, and you don't. And the individual or the patient is not connected to the device. It's essentially like a modem in your house that's sending off signals, and it can detect your movement. So this is and it also is coupled to machine learning. So it uses artificial intelligence to actually learn and improve in terms of its algorithm. And we actually decided to collaborate with Dina to actually use this towards itching. It can detect things like breathing, sleep, gait, if you can fall, and we decide to direct this at scratching. Why not? This would be a great way. You don't have to wear it. You can simply be in your bed sleeping and reflexively scratching throughout the night, and we can detect this. And in fact, in terms of sleep patterns, in terms of sleep medicine, it's actually shown that it's comparable to what they could do within a sleep lab with a sleep technician, this kind of touchless technology that Dina invented. And if we look at actually the Emerald device itself and the radio frequency-based capture of the scratching bouts per hour, or scratching time per hour here on the left, and then we video record these individuals, of course, with consent. We're using a nighttime camera, and what we can find is that we can actually tell when the patient is asleep, and we can also detect this with the device itself. And then we could see how much these individuals are actually scratching, and we can correlate it. And as you can see, the correlation was actually quite tremendous. There was a very, very tight correlation, whether it was scratching time or scratching events per hour. So we think this is a way to actually objectively measure this. But what's really interesting is because you can also measure the stages of sleep, you can tell how much the patients are actually scratching when they're awake. And it's not surprising when one's awake, they would be scratching more. But during REM sleep, they actually are scratching less. But then when they get into a lighter stage of sleep, they're actually scratching quite a bit more. And when they go into deep sleep, less so. This actually provokes an interesting hypothesis, which is that perhaps when you're in lighter stages of sleep, or even so, because it's a reflex, could you be putting yourself into lighter stages of sleep when you scratch? And we know how important sleep is for so many medical conditions, for your cardiovascular health, perhaps even in terms of other neurologic health. So the question at the end of the day is itching really, really important much more important than we thought. On the left side, we think of patient-reported outcomes, so subjective morbidity, which I think is very, very important. And this resides within the realm of the conscious itch. So in other words, if during my conscious awake state, if I tell you my itching is terrible, I can't sleep, I'm miserable, I'm depressed, I'm anxious, it's ruining my relationships, that is important, but it's subjective. And in the realm of Western medicine, it is overlooked. So then can we bring this objectivity using the Emerald device and then actually capture also thereby hidden morbidity? So in other words, a patient might tell you, I was fine last night, I didn't itch at all. But because it's a reflex, when they're asleep, they're actually scratching and scratching and scratching, putting themselves into other lighter stages of sleep. And could this have actually tremendous more morbidity than we ever thought? How much do you know about the unconscious state? If itch affects you both in the conscious and unconscious state, how can we really rely on the patient only to figure out how much this condition is actually impacting their life? And also, I mentioned atopic dermatitis, Prurigo Nodularis, these patients with CPUO, they're not all the same condition, but we use the same subjective metric to actually read this out. So the question at the end of the day is, could we actually now use machine learning and detect different kinds and ways and bouts and frequencies of scratching in these patients to now actually diagnose patients with different kinds of itch, perhaps, even when they're not even awake? And so it really goes much further than just taking an objective stance. So we started with asking what causes chronic itch. We reverse translated this into mouse to identify fundamental new molecular and cellular neuroimmunology. We then were able to inform and accelerate development of new therapeutics. This led to not just clinical trials, but new FDA approval. We were able to then reverse translate this yet again to identify new forms of itch, acute itch, dry skin itch, new ways to measure itch by using new technologies in collaboration with Dina Katabi, and also revise sensory paradigms and think of itch as being a much, much bigger part than just the tip of the iceberg, but perhaps as a much bigger iceberg beneath the itch.